All right, good afternoon, everyone, or perhaps it's morning where you are, or maybe even the middle of the night, but wherever you are, welcome to our 35th seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. I'm Dr. John Pearce, postdoctoral researcher at the Aphasia CRE and co-facilitator of this seminar series. First of all, I'd like to acknowledge that this event and many of our participants today are located on the lands of many traditional custodians in Australia. Today I'm speaking to you from Wurundjeri land, and we pay our respects to elders past, present, future, and extend this respect to any First Nations people joining us online today. Today we have the privilege of hearing from Rene Stolwyk and Sonia Thomas, who are presenting to us on ADaPT, and that's a treatment for depression that's been modified for people with aphasia. And I'm sure everyone listening in to today's seminar knows about the very real challenges of depression in people with aphasia. And so we're really looking forward to hearing from Rene and Sonia today. But before I formally introduce them, I'm going to briefly cover some housekeeping. It's now my privilege to introduce our two speakers today. Rene Stolwyk is an associate professor and clinical neuropsychologist at the Turner Institute for Brain and Mental Health at Monash University. A passionate scientist-practitioner, Associate Professor Stolwyk enjoys working at the nexus of research, clinical practice and clinical education, focusing on improving cognitive and mood outcomes for survivors of brain injury. Sonia Thomas has been working as a clinical neuropsychologist for over 20 years, with the last 10 years in private practice. The main focus of her private practice is modifying cognitive behaviour therapy, so people with aphasia and people with cognitive difficulties post-ABI can participate fully and access the benefits. She also provides supervision and delivers skills training to health professionals across a range of clinical and management areas. So we're really looking forward to hearing about your work, Rene and Sonia, so I'll hand over to you now.
Thanks, John. Can you hear me okay?
Yes.
Very good. Okay, give me a second to figure out the screen sharing stuff.
Yep.
All right, how are we looking?
That's great.
Lovely. Okay. Well, thanks, John, for that very warm welcome. And hi, everybody. So today, Sonia and I want to present our work, and specifically our ADaPT trial, which is looking at aphasia, depression, and psychological treatment. And it's not just Sonia and I that have worked on this project. And actually, one of the things I've really loved about working on this project is the team that we've got to collaborate with. So not only is it Sonia and I, but it's been great working with Ian Kneebone, Dr. Brooke Ryan, and Dr. Caroline Baker as well. So obviously clinical psychology for Ian and speech and language therapy for Brooke and Caroline. So a really great multidisciplinary type approach to this project, which is the thing that I really enjoy. And I really want to also give a big shout out to our superstar PhD student, Priscilla Choko-Rioto. She has really led the research, and I know she should be presenting today, but she's on clinical placement. I'm really presenting on her behalf, so I really want to acknowledge her work. I'm just going to provide a little bit of a background, a bit of a rationale for ADaPT, and then I'm going to hand over to Sonia. As a bit of background, this stuff I'm sure is very familiar to a lot of you. Approximately a third of survivors of stroke experience depression. About a third of stroke survivors have aphasia. And we know that people with aphasia are at a further increased risk of depression. And we also know that around 2/3 of stroke survivors report unmet psychological needs. And the list on the right you'll see there is from the UK around stroke survivors' priorities for community or long-term care. And look at those top three: psychological problems, cognitive problems, communication problems. It's clearly on an area of unmet need. And I think in contrast to a lot of the services that are available for stroke survivors. And that's really an underlying kind of rationale for ADaPT. In terms of psychological interventions for depression post-stroke and for people with aphasia, there's emerging evidence now that supports effectiveness of cognitive behavioural therapies to manage post or ABI depression and anxiety. And I'd like to reference the work of Jenny Ponsford's group, really did some really great work in TBI in terms of modifying CBT for people with brain injury. And it's building in the stroke field. However, most of those studies in stroke have actually excluded people with aphasia. And I think that comes from that very traditional idea that people with aphasia really can't engage in talking therapies. And that's the premise that we're challenging with our work. And it was a really great systematic lit review and meta-analysis by Robert Teasel's group just very recently, actually. And one of their key recommendations was further research, including the use of language modified CBT. So we gave ourselves a little high five for that, because that's what exactly we were doing. So it's nice to be able to address that gap in the literature. We know there's emerging knowledge of supported communication techniques and strategies to modify psychological interventions. And again, I reference Ian Kneebone's work here, really thinking about how can we adapt CBT frameworks after stroke to manage those cognitive and communication issues. And he put forward, I can't remember what year he put those forward, but it was a while ago now. He was really ahead of his time thinking about how that can be done. And there's encouraging findings in the literature now around the feasibility of small-scale psychological interventions and interventions such as solution-focused brief therapies. However, to our knowledge, no studies to date had investigated really the feasibility, acceptability, and effectiveness of a CBT approach to address mood issues for people with aphasia post-stroke. Which brings us to ADaPT. And really, that is our research question. Is a modified and individually tailored CBT program feasible, acceptable, and effective for ameliorating depressive symptoms in stroke survivors with aphasia? So we have, actually, Sonia Thomas, and there's a history here of Sonia who's actually been engaging in this work for a number of years, providing psychological services for stroke survivors with aphasia. And as part of this project, there's a history which we can talk about another time, but for this project, we really thought about, can we, I guess, develop a bit more of a, not so much a manualized, well, in some ways a manualized intervention of Sonia's longstanding work. So we developed a 10-session plus booster session CBT-based psychological intervention modified for those communication and cognitive difficulties. And it's important that both of those are recognized because often they co-occur. And that's what Sonia is going to be focusing on today in this webinar. And I'm going to be focusing on the mixed methods study analysis of the outcomes around that intervention, and we're going to focus today on the single case series. So that's our plan. We've ticked the first box off, the 5-minute intro from me. I'm going to hand over to Sonia now to really summarize the intervention and provide a case study. Then I'm going to switch back and discuss our initial single case series evaluation. And then there'll be some time for hopefully a nice Q&A. So it's at this point, I am going to hand over to Sonia. I'm going to mute myself, and Sonia, let me know when you want me to flick over the slides.
Thanks, Rene. Thank you. So as Rene described there, we did put a manual together to try and really pin down what were the modifications that we needed to be able to adapt the intervention for people who were depressed following a stroke and who also had aphasia. So as you said, that's what I'm going to describe to you now. Just by way of an introduction, I started my clinical work at a very small rehabilitation hospital called Hampton Rehab Hospital over 25 maybe years ago now, and worked with an amazing team of speech and language therapists. And I was able to shadow and observe and be mentored by them to develop my supported conversation skills. And so it really seemed clear to me that we could, even early in my career, adapt our approach to be able to provide psychological interventions for people with aphasia. And that's now a long time ago that's brought us to this point. A bit exciting. Okay, Rene. So as Rene said, we had some discussion about how many therapy sessions would be required. And we arrived at 10, which we felt was the absolute minimum that would be required to treat depression. The sessions were mostly weekly, certainly for all participants for at least the first 6 sessions, and then fortnightly if the participant required. So for some participants who perhaps needed more time to work on the between session exercises or homework, we were able to create greater gaps between sessions, but only ever fortnightly gaps. So after the 10 sessions were completed, at the 4-week mark and the 8-week mark, we provided booster sessions, really to follow up and reinforce the progress that had already been made. So sessions initially started as face-to-face, the way I was trained before we ever heard of the pandemic. And unfortunately, before we even started the first session, we had to delay because of a lockdown here in Melbourne. And once we'd started, of course, 4 or 5, 6 maybe sessions in, there was another lockdown and we had to put the sessions on hold. And then we had to obtain an exemption from Monash University to continue face-to-face because of the great concerns about, obviously, the transmission of COVID, and we had to develop a COVID-safe plan. So we continued with those first 2 participants, but it was quite clear that face-to-face was not necessarily going to work for all the participants. And in fact, as it progressed, we discovered that the majority of participants were going to participate via telehealth. That certainly provided some, I guess, increased challenges, because in my experience, I really had only modified CBT for people with aphasia in person, and felt that that was a much easier approach to take, but we were able to get there and adapt again to be able to provide it via telehealth. Certainly, family members for the people who I saw face-to-face would often come along to the first session, and some for more sessions. Online, for those people who had a more severe level of aphasia, family members would join the online sessions. There were some family members, though, who I didn't see in the sessions, who I made arrangements to provide a 30-minute online education for them so that they understood what we were doing, why we were doing it, and to answer any questions that they had about what they could be doing to support their family member. Thanks, Rene. So the standard approach to CBT is one of training partners, in which the therapist builds up the knowledge and skills of the patient to independently manage their own mood. So in working with stroke survivors, this level of independence is directly related to the severity of their cognitive and communication impairments. So for example, a stroke survivor who cannot independently access the community is able to establish a routine of participating in pleasurable activities with the assistance of family members or friends, or perhaps a support worker, and may be able to learn one type of unhelpful style of thinking and then use a therapist-initiated script to modify this. This may not reach the same level of abstract disputation that a person without an ABI can. However, it may still be effective in shifting the trigger thoughts and the intensity of the associated emotion. So we, based on that idea, developed a manualised approach, as we've said, and the approach really modified specifically to ensure that effective communication and that the techniques were tailored to each participant's cognitive and communication capability. So broadly, each session was structured around 4 main areas: a review of homework from session 2, experiences of the previous week, and for those who didn't have words, that was able to be determined through what I call the basic emotions list, as were the feelings and emotional experiences people had had in the previous week. The second part was to set an agenda and goals for the session. And the third part was to address any key issues through psychoeducation, problem solving, cognitive rehab or general rehab techniques, or through CBT techniques, of course. And then finally to summarize the session and set homework tasks. The other key part was to make appointments for the next session, because as we know, people with aphasia often have difficulty with numbers. So making sure that the time and the date had been communicated effectively was quite important. Next slide. Thanks, Rene. So there were a range of modifications we needed to make for the participants we were working with. Some examples of supported conversation skills are listed there, and for all the speech and language therapists, it's a fairly basic list. But certainly the approach that I took was definitely to speak at a slower rate, to simplify the information in the language I used, to use closed questions or fixed choice questions, to ask about one concept or theme at a time, to ask questions in a logical order from general to specific, to repeat questions and to state what I'd understood and what I didn't understand or what remains unclear. Some of the standard cognitive rehab strategies that I would routinely use, I applied in the study as well, which are things like trying to ensure the appointment is on the same day and at the same time, that a Google invite is provided so that the person's electronic calendar auto-populates. That certainly works for people who are using a digital calendar. Also, I would email at the end of each session with a simple 3-point summary of the key themes or learnings and a list of homework, and attach any documents that were shared online in the session. Thanks, Rene. So as we worked our way through the therapy, I guess there were two key components that we had to make sure before I started that were absolutely required, which was, are we effectively communicating? And to do that, I would find out all the information I could from speech and language therapists, from the family, also find out about the person's online capability, the kind of modifications that may have worked previously, and ways to maximize the person's ability to express themselves or to comprehend. So that required quite a bit of preparation before the session, and then I would be clear about how to support conversation and cognition during the session. As I said, as we went along though, we used visual tools to support communication for enjoyable activities. So for people who struggled to express themselves and perhaps had no words, thanks Rene, we would use something like this, where I could work my way through the photos there and ask yes/no questions. So in the options column, do you like to go out on a motorized scooter or outside for a walk? And the person, if they had no words, could still give me a thumbs up or a thumbs down. Or some of them gave me a so-so. And we could work our way through those photos. And then I would type through this shared document the activities they endorsed. I would also type, even for people who had words, whatever the activities were that they mentioned, and just checking with them if that what I was writing was correct. Next one. So this is a visual tool that I've routinely used to support people expressing their emotions, and also as a way to monitor where those emotions are throughout the therapy session. So besides me asking, have you felt happy today and in the last week? I would also highlight happy. And if the person had cognitive impairment in terms of being distractible, I would only show the happy and the happy face rather than the whole list. If they endorsed that they were happy, then I would show them a like-it scale from 0 to 10 and ask them if they could tell me how happy they had been in the last week, where 10 was as happy as they could possibly be and 0 was not. So again, for people without words, they were able to say 7. And for those that could, they gave me a verbal response. Next one. Thanks, Renee. So we also use diagrams to, again, try and convey with as little words as possible. So this particular tool would be what we use to explain the C in CBT. So we'd start off by focusing the person on the feelings, the centered circle, and explain how people usually are aware that they're depressed and usually aware that that depression leads to particular behaviours like feeling tearful or avoiding activity. What most people are not aware of is that it's thoughts that have triggered those feelings that leads to that behaviour, such as I'll never be the same, the stroke has totally changed my life. So slowly at the pace that the person can manage, we would work our way through using the arrow from the cursor to keep them on track. Thanks, Rene. This is also a very common thing in CBT, is explaining how thoughts do impact our emotions, and usually with an example. So the example that I gave, I was able to provide with both photos and a small number of written words. So in this one, I'm on a blind date. The blind date spills red wine on my dress. And in the first instance, you can see that my thoughts, how dare he ruin my dress? What an idiot. This is a total disaster. And then we talk about that thought is an expression of emotion, and that the emotion would probably be anger, and quite a high level of anger, and so on. So you can see then we contrast that with a different kind of thought that leads to a different kind of emotion, different intensity of emotion, and a different kind of behaviour. So again, working as much as we can visually and with lower density of words that I say and more words that can be read. Thanks, Renee. Right, so for people, of course, who don't have words, accessing thoughts is a very tricky thing to be able to do for a therapist. How do we find out what they're thinking if they can't tell you? So one of the ways that we approached that was to provide examples of possible thoughts that people experience who are depressed. And that allowed the participants to be able to endorse ones that were relevant to them. And mostly I would ask, let's say they endorse this second one, there's no point, nothing works. I would ask, is that exactly what you're thinking, or is it just in the ballpark? And so for those who say, yes, that's exactly what I'm thinking, then we can work together to show them how to modify it. If it's in the ballpark, then I can start to ask questions based on my knowledge and understanding of them as a person and their experience of their stroke, to try and through yes, no questions, get closer to the thought, if not to the exact thought that they have. Thanks, Renee. So when I first started this work, a clinician said to me, are you sure that people with aphasia have thoughts? Yeah, I was shocked at that. But just to answer that question, if any of you were wondering, these are 10 examples of the 10 participants that I worked with, and just one of the thoughts, unhelpful thoughts that they had. What I think us as a team found interesting was, probably not surprisingly, a good number of these are unhelpful thoughts about their aphasia, about the problems they have communicating. But also, interestingly, some are quite similar to other stroke survivors in terms of the types of unhelpful thoughts that we would see working with that group of people. Thanks, Renee. The modification to thoughts would normally occur through a thought record. So we would use really a table structure that would assist people in therapy to be able to identify the automatic thoughts that they have, and then work together on how to modify those. And certainly that needed to be modified for the participants in the study. And sometimes we would start with one particular approach and then I would need to adapt it as we went along. So for example, one participant found writing very effortful, and for 2 sessions was able to make entries in a standard thought record. But by the 3rd session, she stated, "I'm sick of the thought record because I cannot write and hate it. It's not how I want to come across." So this was a clear message to me that I needed to modify the approach to increase the support of the participant communication. So the following session, I introduced the Thought Diary mobile app. And we worked through an example of her unhelpful thoughts on the app. You can press the slides forward, Renee, sorry. Yes, there it is. So we worked through an example on the app using my second camera, and then I sent her step-by-step instructions and using screenshots to follow up after the session via email. She was very positive in the next session and had been able to use voice to text to make entries in the app, and continued to use that very effectively. Another participant with English as a second language and cognitive impairment required written step-by-step processes for modifying thoughts. So you can press the slide again, Renee. So stepping through how you modify thoughts in a very explicit way was crucial for this person. So you can see the thought was, this should turn out the way I want it to, or I can't stand it. And then there was a range of potential questions we could use to challenge it. And we arrived at the ones that were going to be most effective. And then we were able to write down, or I was online as we worked, what the modified thoughts were. And really, as you can see, the more explicit and the simpler, the better. A third participant who struggled to comprehend who struggled to comprehend full stop. Sometimes he struggled to comprehend even the words that I'd written down. So I needed to see in really simplified writing how to get across the idea of patterns of cognitive distortion that were demonstrated in his thoughts. So again, can you press on, Renee? So this is, again, a very explicit way of highlighting the common thinking error, writing the very simplified thought that he had. You can see we also were able to rate the intensity of his depression and then work out the modified thought and how effective that modification was in terms of lowering his depression. So even in terms of the number of words and the internal critic, in retrospect, I think I could have simplified that even further. For this particular gentleman, though, he was able to engage and made some progress here. Thanks, Renee. All right, so I'm now going to talk to you about, in more detail, about one of the participants in this case study. He was a 48-year-old married man, a commercial pilot, was studying law part-time prior to his stroke. He had a left middle cerebral artery infarct in November 2020. He had 2 children, both of them born since he had the stroke, one now 2.5 and the other 1-year-old. He was born and was working in the United Kingdom. He relocated to Australia in May 2022. The main consequences of his stroke was his aphasia and depression. So his comprehension was good. He had mild to moderate word finding issues, and mainly his speech consisted of 3 to 4 word phrases. He described himself pre-stroke as quite a happy and optimistic fella. He, as I said, had been a pilot. He worked in the Royal Navy. He was posted twice, once to Iraq and once to Afghanistan. He described symptoms of PTSD after the Afghanistan posting, but not formally diagnosed. He also described symptoms consistent with a depressive episode at the end of his first marriage in 2013, but again, not formally diagnosed. He was on a low-dose antidepressant, which he said evened out his mood. Thanks, Rene. He indicated he'd been depressed 7 out of 10 and that was all the time and mostly about his speech. He said, can't speak, sort of speak. He felt quite isolated by his speech, reporting can't email, phone. And he was referring to friends and family in the UK. He had a very negative view of his future due to the aphasia. He often felt confused in conversations with his wife in terms of understanding numbers, dates and times around her work timetable and the children's activities. He was the full-time carer for his 2 young children and he found that role quite overwhelming. So for the psychologists out there, my formulation was that his precipitating factors, really the main one was having aphasia and stroke. The perpetuating factors were the stress of being a full-time parent of 2 children under 3 and the isolation of his communication impairment. The predisposing factors were that he had perfectionistic tendencies, that he was quite young, that he'd moved away from family and friends, and that his expectations of recovery, given the time since the stroke, he expected when I first met him that he would have been fully recovered. The protective factors, importantly, were that he had a very practical and emotional, practical wife, emotional support from both his wife and children. They had financial security due to his wife's full-time employment, and he was highly intelligent pre-morbidly. Thanks, Rene. So he certainly lacked confidence initially in his communication. He was very apologetic when he couldn't get his message across. So there was a number of modifications that I made to my communication, as you can see there. What was fantastic was that he initiated his own strategy for numbers. He knew that they were problematic and he would always write them down and hold them up to the screen to check accuracy. And if they were incorrect, I would record the correct numbers and hold them up for him to see. He responded very well to activity scheduling, although he did need an increased amount of activities in terms of his activity list of activities, enjoyable activities. What was great was he had a good physical recovery and he had previously enjoyed running and continued to enjoy running, describing that his brain is quiet, don't need to speak. He in fact managed to run I think a full marathon or a half marathon, whatever it was. I felt it was very impressive, and continued to pursue that. His metacognition, or his thinking about thinking, was very good. He had great support, as I said, from his wife, particularly when I initially asked him to generate unhelpful thoughts. They sat down and did that together. And the examples were, I cannot ever say what I want to say to my wife and kids, and I will never return to any type of work. I'm totally useless. He was quick to understand the idea of disputation and modification. And I think the thing to say about the modifiers for people with aphasia is they're often short. So for a negative what if question, his typical modification was wait and see. So for example, he might say, what if I never return to work? And we were able to question the evidence for that and his tendency to future tell, so to try and tell the future. And so he was able to challenge that and bring that back to the simple modifier of wait and see. He had steady improvements in mood between sessions. And by the time that we'd finished, his mood had shifted from 7 out of 10 to 3 out of 10, which was a significant improvement. And he was modifying his thoughts on a consistent basis. Thanks, Rene. So there were a number of barriers, not surprisingly, to participants learning and adopting CBT skills, and barriers to achieving improvements in their depression. So for some of them, there was limited to no family support and therefore no conversation partner or anyone to advocate for them or assist and help them in achieving things like increasing the enjoyable activities they were doing. Some of the participants had psychosocial complexity, such as being separated from an abusive spouse, undiagnosed hoarding disorder, narcissistic traits, or financial complexity. Some relationship dynamics were not helpful. So somebody might think that they're helping by taking over tasks and directing how they're done. But what I was looking for was more of a collaborative partnership. Some participants had quick improvements in mood, but for one in particular, it led to perception that they were cured, and so they had no need for treatment and stopped doing any of the tasks that were helping them, including ceasing the medication. COVID lockdowns were clearly a barrier, and the limit of 10 sessions was a barrier too. Some needed many more, and one size did not fit all, particularly for those with moderate and severe depression. And 4 weeks to the first booster was too long when the CBT skills were not well established and there had not been enough shift in mood. Thanks, Rene. Back to you.
Lovely. Thanks, Sonia. So we're going to, now that Sonia has given a fantastic summary of the intervention, I'm going to move on and really talk about how we evaluated this very novel psychological intervention. And because of that novelty, this is really breaking new ground. We really started to, we started from really a phase 1 approach, thinking about how do we evaluate this, really looking from a feasibility, acceptability, and really starting to get some ideas of signaling for kind of effectiveness of this intervention. And that's why we chose a single case experimental design. But that is our research question that I already covered. In terms of the participants for this SCED study, we had 10 stroke survivors with aphasia and depression. And I won't go through all the inclusion criteria there, but they're pretty self-explanatory, that they obviously needed to have had a stroke. They had some degree of aphasia, and we were quite keen to actually get a range of people with aphasia. They had to have self-reported low mood, and we had that as a score of 2 or more on the discs. We can talk about the discs later in terms of how well it functioned as a measure of mood. And there's some other, obviously, inclusion exclusion criteria as well. In terms of the materials and procedures, in terms of the design, we used a randomized multiple baselines of 2.5, 4.5, and 6.5 baseline lengths. Then phase B, that was phase A. Phase B, the intervention was with the 10 sessions, and then we had a 4-week follow-up. There is a booster kind of phase to the study, but we're not talking about it here. And in terms of outcome measures, so the discs was our primary outcome measure. We also had the SAD-Q, which is a close other report of mood, and we also had a close other report of anxiety as well, which is the behavioural outcomes of anxiety, the BOA, in addition to some secondary measures. This is the discs for those that aren't familiar with it. It's a very simple tool, which was great in terms of it being able to accommodate the range of severity of aphasia we had. And we had some, obviously, some participants with quite severe expressive and receptive aphasia. And this is can accommodate that fairly well in terms of participants really just need to, I guess, colour in the degree to which the circle is in grey is reflective of their severity of their depressive symptoms. And this is an example of the SAD-Q, which is where a close other really rates their close others symptom or their behavioural symptoms of depression. In terms of data analysis, we used a mixed method approach of both visual analysis between and within phases, where really we looked at trends of results over time visually, in addition to statistical analyses across phases using the tau U statistics, which is a fairly common kind of combination of analyses for SCED designs. We also had our secondary analyses, which we call them secondary, but I think they're very much as important as those primary analyses around feasibility. So we looked at fidelity and adaptation. We've got some measures of treatment adherence, which are undergoing at the moment, and also qualitative observations of modifications. We have acceptability, and Caroline Baker has led those qualitative interviews. She's our independent. She's done some fantastic qualitative interviews looking at the participants' experience of ADaPT, and then the practicality of some of our assessment measures as well. In terms of, sorry, I'm just whipping through this fairly quickly because I want to leave some time for Q&A. So apologies if I'm going quickly, but feel free to ask any questions that I skip over. In terms of participants, we screened 32 participants. Of that, 11 participants were recruited. One was ruled as ineligible after the fact, which was slightly disappointing, but that happens in clinical research. One participant withdrew after 7 sessions. We have still included the data here, and 9 completed the intervention. And that gives you an example on the a bit of a flavor on the right of the I guess the variability within our sample in terms of age and aphasia severity. Please don't ask me lots of in-depth questions on the web because that's not my area of expertise. It's always intimidating speaking to another discipline. Surprisingly, and if we could have a discussion at the end, an unexpected, given the prevalence of aphasia and depression that we know after stroke, we were actually quite surprised by that. We did have some challenges in recruitment. Overall, we had limited referrals, and apologies for those people on BrainSpan. I have been spamming your emails inboxes for recruitment. We found it overall the number of referrals was limited, but also an interesting dynamic. We were given referrals by a clinician or a close other, and then once we actually spoke to the stroke survivor themselves, either they weren't really acknowledging that low mood or really didn't feel that was a goal for them at the time. And often that was caused, due to maybe significant comorbidities or life stresses as well. So combination of not acknowledging their low mood, maybe due to stigma, but also just the complexities of life sometimes. So it's interesting because we potentially are keen for a next phase of the study, and I'd love to talk about that challenge if we were to move to a bigger trial. In terms of just a bit of a quick rundown on SCED analysis, this is what our data do look like. You can see here you've got the 3 phases of baseline, intervention, and follow-up, and we used a difference in baseline length across participants. You can see here the different baseline lengths. These grey bars represent the intervention sessions. So you can see here, this person's had a gap in an intervention session, and that's important for later because some of our participants had quite a gap between sessions, particularly when we started in that COVID lockdown. And the way we analyze these data were, we can use trends. So this line represents the trend of the dots. You can see there's a kind of an improving trend here at baseline. Or we can use actually kind of between phase kind of averages, which is in here. You can see it's fairly constant across baseline and intervention, and then there's a reduction and follow-up. So those are the things that we're looking at when we're analyzing these data. So I'm not going to go into detail for all of the participants. So I've got a couple of case studies that I can show you, but you can see here some examples. These are our first participants here, and just a few, I guess, patterns of performance that we did see across the participants. Some were maybe not so positive. You can see here, BB here had a slight kind of deterioration during baseline, and actually, unfortunately, continued to deteriorate throughout the intervention. We can see here someone that was fairly stable during the baseline. There was some improvement during the intervention, but then some deterioration post-intervention. Wasn't a great start to this study, and there were so many challenges with it, and the fact that we tried to start this project right when the first lockdowns happened during COVID. And you can see here, look at that big gap where there was just no intervention provided. So you can see here, Sonia really only just got to get started on the intervention. There's this massive, I guess, gap in therapy provided, and then we tried to carry on. It was very disruptive. And I think that when we look at the summary of results, I think that plays into it to a large degree. Other participants had a much more, I guess, positive response. You can see FF here, fairly stable baseline, but a really nice reduction in depressive symptoms during the intervention, which was held over baseline, and same for II there. So overall, when we summarize it, what we can see here overall is unfortunately, in our first group, where we were really struggling, I think, with getting the interventions in place and moving for telehealth and all that types of things, we got a fairly mixed response, with particularly this issue around deterioration during follow-up, which Sonia made the really good point around that gap between intervention and booster when those skills weren't really fully developed. However, as we went through and really got our intervention a little bit more put together and really managed those telehealth issues, and also had more opportunity for face-to-face, see a much better, result in terms of a number of participants improving during intervention and either maintaining that improvement, or we actually also noticed this kind of delayed improvement for a number of people, which was really, really interesting and quite positive. But by no means, I think we need to acknowledge here, by no means is this a 100% kind of success rate, and that really does reflect psychological interventions more broadly. And we're quite interested to look at really comparing other interventions, both around response to treatment rates. In the interest of time, I'm just going to quickly, I'm not going to actually go through the data here, other to say the SAD-Q, which was the close other measure, was actually much more positive. Again, some issues at the start, but by the end, we're getting really consistent positive results from the close other. And we're not sure whether that's a close other issue or whether actually the SAD-Q is just a lot more sensitive and accommodating to the degree of depressive symptoms. We feel that there is a restricted range with the discs that may be causing some issues, but overall getting more positive response from the close other interpretations of their close others' depressive behavior. And again, I might just skip these case studies because I know we're at 9 minutes to go. So I might just skip now to the conclusions, which is where we find, in terms of the main data conclusions, was 5 participants improved during the intervention phase, and improvement was sustained at 3 participants, and additional 3 participants improved during the follow-up phase. And as I mentioned before, the close other results were a little bit more positive with that. Our learnings from this trial is we're not sure that 10 sessions are sufficient for people with aphasia. So that's something that we're going to be taking away. And we've really learnt the importance of consistency of sessions, particularly when we don't have these pesky COVID lockdowns. We really valued, as Sonia mentioned, that involvement of a support person, particularly to implement the support implementation of the strategies outside of sessions, and the opportunity to apply and generalize strategies. So overall, what we feel we've contributed in terms of both to research and clinical practice is really some techniques and resources to help modify CBT for individuals with aphasia, and really inform the feasibility of conducting a similar trial at potentially a larger scale. And I think maybe that's just a bit of a repetition there. So, and in terms of future directions, we're very keen to utilize these data and also the qualitative data to further optimize our ADaPT content and delivery. So this, I think we've learned some fantastic things about further developing our intervention. We need to address these issues around depressive symptom measurement for people with aphasia to really accommodate that diversity of aphasia as well. And deep breath, do we now progress to a phase 2 RCT as well? Like to acknowledge the stroke survivors and their close others for participating, the whole ADaPT team, and also the CRE for funding this project as well, and the ongoing support of the Stroke Foundation, particularly around recruitment. I'm going to leave it there. Sorry, John, we've been a bit over.
No, that's okay. Look, thank you so much. It's as a speech pathologist, it's easy to sometimes feel like, you know, we're the only ones flying the flag for aphasia, or sometimes people around you will kind of be like, oh, aphasia is your thing. So it's just really inspiring to have other disciplines and other professions researching. So yeah, look, thank you to you and the team for doing this research, and thank you, Sonia and Rene, for presenting it today. If people can just type in their questions and also start voting for the questions they think are most important, and we'll get to those. I'm going to steal the first question spot, or rather discussion. You know, the issue you mentioned around recruitment is just fascinating, because it's impossible to work in aphasia or to know people with aphasia and not bump up against mood problems somewhere. So, I mean, yeah, do you have a hunch as to what the barriers are, what the block is?
Look, I think one of the issues that we encountered quite regularly were that clinicians and family members were contacting us saying, hey, my close other or my client has low mood. We think it would be great for the study. And there were a number of occasions where when we actually contacted that person, they're like, no, and no thanks. Yeah, and despite quite a lot of engagement. So that was a bit of an issue. So maybe we can work on, I don't know whether we could work on potentially some process of engaging people before going, hey, do you want an intervention for depression? To actually engage a little bit more around how they're feeling, you know, a bit more of a motivational interviewing approach maybe to start with, to really understand what their issues are, and a bit of psychoeducation. It's always hard in a research context to do that. But that's maybe one issue, but I'd really like to flesh that out a little bit more and understand actually maybe for the audience's perspective about what they think might be going on. Yeah,
look, it's a little bit difficult in this forum because we can't open the cameras or anything, so we can't have an open discussion. But yeah, I mean, you wonder. It's no good when someone's partner tells them they're depressed, or someone's, you know, friend told. It has to be that person that says, I need to go to the GP and I need to, you know. So I wonder if nominations from someone else just aren't enough to push them into action. I don't know.
Yeah. And look, I think COVID did not help. People were just bunkering down and trying to survive. I think that was a part. The telehealth aspect, I think, was an additional kind of challenge because of COVID. I think there are a mix of issues going on, but I think there's something broader than that. I don't know whether it's stigma or education. I'd like to know more, particularly because we think this intervention has real potential and would love to progress to a bigger study, but we need to be sure that we can actually recruit those numbers.
Yeah. Oh, were GPs a source of recruitment, or?
Not specific. We didn't specifically target GPs, but actually that's a good avenue. Maybe that's there are some really good forums for GPs, so that's possibly a good option as well.
All right, we better get to the popular questions. So Peter Rankin has asked a double-barreled question here. First one is, to what degree do you think the direct brain damage from a stroke plays a part in depression? So I assume that's kind of asking physiological versus situational causes of depression.
Yes. Oh, go on, Rene.
No, you go, Sonia. That's fine.
I was going to say yes. There certainly are particular areas of the brain that can be affected by stroke that are associated with depression. So the answer is that it's both. and it really depends on what type of stroke and where the stroke occurs.
Yeah, I think we're all settling on this biopsychosocial kind of model of depression and acknowledging not only those biological variables, but also the psychological issues. I think pre-existing mood issues are a significant risk factor for people with depression after stroke, which is probably not surprising, but also level of disability. And yeah, there's a whole research field around this. But really, it's all of those biological, psychological, and social factors.
So
contribute.
If the question's to what degree, do we have that precision yet to be able to look at proportions, or is it just?
Look, not that I'm aware of, but I think it's probably, where the literature is at the moment is that it's not just biological, it's not just psychological. Any of those factors can contribute, and they can also interact to also increase and impact on the severity of depressive symptoms.
Yep.
Yeah.
So the follow-up to that question was, does emotional lability in stroke affect the propensity for depression?
Good question.
So I would say that there's perhaps an interaction between emotional lability and depression. So in that somebody who is depressed is going to be crying a lot, so that they might not, because they're having difficulty regulating their emotions, the expression of depression is likely to be exacerbated for someone with emotional lability. I'm not sure. I think this is sort of saying that if you've got emotional lability, are you more likely to be depressed? And I think the answer there is no.
You may appear more labile if you are depressed. Is that?
Yes, but also if if you have emotional lability, it might mean that you laugh a lot and in inappropriate times. So it's not necessarily a consequence that relates directly to depression.
And I think the risk of being misdiagnosed with depression for someone with emotional lability and aphasia, particularly a doctor or a GP sees someone crying and they can't communicate, it's often assumed that they are depressed, whereas actually a more careful kind of assessment would actually identify maybe they're not even depressed at all. So actually the risk of misdiagnosis of depression for people with emotional ability is very real. I've seen a number of people with emotional ability on antidepressants, and I don't think that's necessarily the most appropriate thing.
It's an interesting problem, isn't it? Very popular question is, I wonder if any of the resources are available for use by speech pathologists to screen for depression, etc. And that's from Liz Chard.
So I'm not sure if you're talking about the DISC, because the DISC is widely available. If you're talking about the emotions list that I showed, I have answered a few in already, just in writing in the background while Rene was talking.
Oh, you have to. Sorry,
I know, that's right. Just because I thought we'd run out of time. And what I've said is that because this was a case series and we do want to do a second part to this work, we also want to feed in the results from the study into developing the resources further. So in short, at the moment, no, the resources are not going to be publicly available yet.
Yes. Because the questions have poured in, are you happy to just go a few minutes over and answer some of these?
Yeah, sure.
Sure. So perhaps we'll jump into the ones you've answered just for the people watching the video. One of the popular questions there was, any plans in the future to trial ADaPT with culturally and linguistically diverse people with aphasia through interpreters?
Yeah, so there was one in the study, 1 of 10, where we used an interpreter. And really, it's, I guess, about the size of your sample. The larger the sample, the more chance there is of getting that diversity.
Yeah.
But certainly, we've shown one example of being able to work with an interpreter with this type of approach.
Yep. Kim Beasley asked, how many sessions do you think may be required? So
I responded with about 15 to 20, but that's my clinical judgment. Certainly, I think for people who are struggling with acquiring that metacognition, that thinking about thinking, that you need more time with those.
Yeah, it's quite an abstract thing, isn't it?
Very.
Yep.
Yeah.
Miranda Rose has asked, are there any studies that have used the discs as a probe measure showing stability across multiple time points? Given poor stability in baseline for most people, it seems a very poor probe measure for single subject designs. And there's a part 2 to that question, but I'll start with that.
We haven't looked at that. We've started to, but yeah, that's where we're at the moment. Miranda is trying to understand more about the discs. At the time of this project, we talked a lot about what would be the best option for our primary measure, and we did settle on the discs mainly because we felt it was more feasible than, particularly if we had more severe, dealing with people with more severe aphasia, it would be a feasible measure. But yeah, we're now at a point, and Priscilla's really getting her head into the psychometrics of the discs, the strengths and weaknesses. Overall, actually, there's very little, there's limited evidence around the psychometrics of the discs. Actually, more broadly, this is an issue in the field more broadly, and this is something that we're starting to think about, is psychometrically robust measures of mood for people with aphasia. There've been some good kind of systematic lit reviews and meta-analyses recently, but and they're great reviews, but they're all coming up with the same results as we need to do better. So that's the challenge that we're in at the moment. We want to, so that's what we're looking at. There's lots of different, there are some options, and that's going to be part of what we're looking at moving forward.
The other thing, just to say clinically, is that it's not clear whether it was the disc that created the instability in the baseline. Certainly there are studies that show that people can start to improve in a baseline knowing that they're about to enter therapy. But on the flip side, you can get people who deteriorate because they're having to wait to start therapy. So that isn't necessarily to do with the measurement. That can be more related.
I think our frustration with the discs is less about variability, but more with restricted range. 0 to 5, it's just a really restricted range. So we're not feeling like we're getting the sensitivity of symptoms.
Exactly.
Yeah. What is 1 point? Like, what does it mean?
Yeah, it's a very individualized kind of measure.
So the other part of Miranda's question was, she was wondering whether COVID environmental issues negatively impacted the probe measures. The negative reaction to COVID experienced by almost everyone, including these participants, may have masked possible strong positive effects of the intervention.
So I think there were probably some of the participants who had very positive effects from the intervention. And that said, we all struggled with the impact of COVID. Even those of us without the challenges to our psychological resources that someone with aphasia and who's had a stroke has. So it was a confounding factor.
Yes,
for sure. Particularly, Sonia, you've talked before about how particularly the behavioural activation side of the therapy was really restricted due to COVID, particularly when you're having to deal with the more behavioural elements. If that idea is to socialise or to, get out there and do things, that was hard during lockdown. Well, it was not allowed during lockdown. So, Miranda, I think you're right. It was, I think COVID did, there's a high risk that COVID did really temper the effects of the intervention.
I mean, we're all kind of, if we were locked down, planning what's the positive thing I'm going to do today or this week in my house, so how do you, Look, there are a lot more questions. I'm just wondering if we could point people to somewhere where they can ask them offline, because we have run out of time. Is Twitter the best avenue, or?
Yeah, and I tweeted one of our slides that wasn't the resources or the results. So you can look for me. I'm at Rene_Stolwyk, or feel free to email me as well. I know, Sonia, you're not on Twitter. In fact, a lot of people
I am, but I don't tweet.
Okay.
Oh,
I have no time to tweet. I'm sorry. I'm not on any social media because I don't have time.
That's all right. So email.
And I do have an email. I'm happy for people to email if it's a clinical question, but if it's easier just to send them to Rene, and he can send the ones to me that he'd like me to answer. Perhaps that's the best way to go.
All right. Thank you very much. Look, thank you again for your time today in presenting this, again, really, really important study. And we're excited to see what happens next with it.
Thanks, John.
Thanks for inviting us.
No, pleasure. Now, for our next CRE seminar, we're very fortunate to hear from Dr. Kira Shiggins, who has hosted this seminar series in the past, and she's going to be presenting on the consistent inclusion of people with aphasia in stroke research. This seminar will take place on Wednesday, March the 1st next year, so follow us on Twitter and via our community of practice for details on how to register for the seminar. Thanks very much.